I get some questions recently about how do psychiatrists diagnose these disorders and what happens during the first psychiatric visit. It's different in psychiatry versus other fields of medicine when there's more objective findings. We have blood tests, you have scans, you have echocardiograms, you have EKGs, you got CT scans. So you got a lot of ways of visualizing the body for things. But psychiatry is different because I call it an invisible illness. It's something you can't see with the naked eye. It's microscopic. And if you've seen my show and look at what I draw on the board, you're going to see it's all really neurochemically based. And so how do we diagnose it? Well, it's all really based on history. And, so the first visit, what I do with my patients, I have them fill out a form online. If you want to see it and go on my website, you'll see the form I have people fill out. It's pretty extensive. I ask a lot of questions. So what I like to do is read through that before the visit, and that gives me a lot of baseline information to work with. And then it's really sitting down with people. I evaluate them, how they look. I'm evaluating everything while the person's there. How they act, what their mannerisms are, but also all the history. So I ask about every symptom they have. I ask about, do you get physical symptoms? Do you get headaches? Do you get neck and back pain? Do you get stomach problems? All those things, joint pains, irritable bowel, fibromyalgia, chronic fatigue. A lot of these things are neurochemically based, which is why, you can't get blood tests for these things because a lot of people can, especially these muscles, a lot of people can relate to like when you get stressed out, these muscles tighten up. So I get all the physical symptoms, emotional symptoms, worry, rumination, obsessive thinking and behaviors. Do they have obsessive compulsive behaviors? Do they have anxiety symptoms? What are the symptoms? Are they having problem breathing? What are the symptoms of anxiety? Do they have panic attacks? So I ask every detail about every symptom they have. If they feel depressed, I'm asking about their motivation, their energy, their drive, and of course, you always have to think about, asking about suicidal ideation because that's, pretty much every new visit I ask about that, or if they've ever had any kind of thoughts about suicide. Because that really, if that takes it up to the next level, if you hear that, that means, that it's really important to get the person treated. And then, so that and, family history is very important. So I get about their parents, their siblings, their grandparents, so try to look at the family tree and see like what side this might be. It almost always is genetically based. It's often hormonally based. This is why a lot of times I see people in middle school, or if someone gives me a history of when they started feeling the way they feel, it very often starts around puberty. So the first main hormonal change in life. And then women have it worse than men, because women have premenstrual times, they got postpartum, they got menopause and pre and peri and post, and so men, we got puberty and I call menopause. Menopause is, or midlife crisis. So men also go through hormonal changes during those 40s and 50s years that can impact things. That family history, what medications have you tried in the past? What did they do to you? Did you like them? Did you not like them? What didn't you like about them? So it's very every little detail I record. And then when I get a good first visit with all the details, then when they come back or next week, I read through my note again, and then ask them, well, tell me about this or this, So I'm able to kind of figure out like what to give them based on the totality of their symptoms, not just one little thing, but everything taken together. Does it look like they're more unipolar? Are they looking more bipolar? How should I address it? Should I start with antidepressants? Should I start with a mood stabilizer if I think they're bipolar and not an antidepressant? So all those decisions come after taking a really good history and deciding what to do. And then you make an educated guess. It's trial and error. it's trial and error based on science, and it's trial and error based on experience, but it's still, everything's trial and error in this area of medicine. But it's not like throwing darts at a dartboard. There's a specific reason that I make the decisions I make based on the history. And then when they follow up or they call me, because I have every new patient call me a week later, because I can tell within a week if I'm on the right track or not. If the diagnosis is correct, if I've chosen the right medication, and if not, within a week I stop it. I try something else right away. So these things work. Medications work quickly, and when they work great, it's amazing the results. Sometimes it takes longer. Some people 1 or 2 visits is all it takes, and they're doing great. I have a patient that came in recently, just this week, and she had a complicated history. Saw different doctors, and a lot of time and money. And I took a long history from her, and I just said, well, based on what you think, just increase the dose of this, and then put this back in that you took before. And now she's 2 weeks later, our last visit, she's blown away. She said, I haven't felt like this since way before I even started seeing a psychiatrist. So it was a very simple thing. And then she was confused. She said, well, why didn't they do this? And I said, well, kind of a long story. But basically, doctors have different ways of doing things. And especially in the area of mental health, there's way more happens in this field than any other field of medicine by far. But again, it's just a matter of looking at things the way doctors look at things, and I've disagreed for many, many years about how most doctors do things. Recently, I released 2 new books that have come out. The Corona Protocol, 3 Secrets to Success, and the Corona Protocol Prescribers Guide. And in these books, they're really meant for doctors, nurse practitioners, physician assistants, people who can prescribe medication. I think most people would be kind of bored with them, and they're kind of tedious if you're not used to this stuff. But my intention is to teach doctors, because I've seen this problem for many, many years about how just poor treatment of mental health conditions out there, and a lot of people are suffering. A lot of people are hopeless. A lot of suicides are happening when they could have been prevented. So it's driven me for so many years to the point where I wrote these 2 books, which took a lot out of me. But I'm glad I did them, because I'm hoping to make a difference out there, and I'm hoping to go out and do some lecturing and speak and talk about this stuff. So hopefully doctors can get on board and start to really see things in a different way. Because I think that the traditional psychiatric way has really failed a lot of people, and not all of them. I mean, there's good doctors and bad doctors, and it's not always about good and bad. It's about your training, and you're taught to see things a certain way, and sometimes you get stuck in that mode, and that's just what you know, and you can't back up and say, well, I mean, I need to maybe look at this in a bigger picture. Maybe I need to do things a little bit differently. If people are telling you you're coming in and this isn't helping me, you got to listen to them. And if you just say, "Oh, I'll just give it 2 or 3 more months," it's just then that's 2, 3 more months of suffering that a person doesn't need to be in. And so anyway, so I can go on about this because I'm very passionate about this subject, of course. But anyway, that's kind of in a psychiatric, at least in my visit, that's what I do. Is I take as much of a history as I can. And then I follow the person really closely. I do a lot of phone calls in between visits that I don't charge for, because I like to tweak things and try to do this before our visit, do this or do that. And so I do a lot of that to try to get people better as quickly as I can. So anyway, thanks for listening.